So it's 12:05, and thank you everyone for joining us today. I would like to introduce Dr. Joseph Sullivan. He is the professor of neurology and pediatrics at the University of California in San Francisco and the director of the UCSF Benoiff Children's Hospital Pediatric Epilepsy Center of Excellence. So without further ado, please proceed, Dr. Sullivan.
Right, great. Hello, everyone. Thank you for the invitation. I was asked to speak to you all today about some of the new anti-seizure medications. And the title may have even said anticonvulsants or anti-epileptic. This has been a new sort of terminology shift yet again. Us in the epilepsy space, as soon as you get comfortable with like a term, we want to change it again. But I think that this actually is more appropriate because the medications, really, let's call them what they are, right? They're really meant to be treating the seizures, and unfortunately, they're not necessarily treating the underlying epilepsy process. So I'll refer to ASMs or anti-seizure medications throughout this talk. And this is almost identical to the talk that I gave a group of physicians this morning. I know that parents and caregivers and patients that often attend conferences like this are coming in at such a high level that I feel that for the purposes of this type of presentation, I can deliver it to you on a high level as well. So I think we decided to take questions at the end, but if there is a burning question, this is supposed to be informal, so feel free to unmute yourself and speak up, and I can try to address it at that point in time. So these are my list of disclosures, some of which are relevant because I've been involved with some of the research trials that I'm going to present the data to you today. And so the learning objectives, right? We start out, for those of us that our kids are on Zoom sessions now, education, right? We have to understand, why are you all here listening to me talk? Hopefully that at the end of this, you will be able to understand the data that led to the approval of some of the new medications that we'll talk about, to talk about the different side effects. And then, this is more from the physician, but again, parents that come into me, they very often have sort of an agenda. And I say that with the utmost respect, right? They have an agenda like, this is what's worked, this is what I've read about, this is what I think I want next. And so hopefully this will be helpful in that way too. So first, let's just go over some sort of nuts and bolts of sort of epilepsy, seizures, syndromes, and what all of that means. As a pediatric epileptologist, until these new medications have come onto the scene in the last 6 or 7 years, we were kind of held hostage, I would say, to our adult colleagues, because the overwhelming majority of medications, new medications that came to the market, were studied in adults, and they were studied in adults who had treatment-resistant or refractory focal epilepsy. And we certainly know that there are many other different types of epilepsy that are common in the pediatric population. More recently, there has been a shift, and maybe I would argue, maybe even too much so. Have we gone too much to the syndrome? Because you have all these parents out there that are saying, "Wait a minute, my kid doesn't have one of these syndromes. When are you going to pay attention to me?" But more recently, there's been this shift towards these specific epilepsy syndromes. And this is a figure that I always like to show to trainees and residents and fellows. And it's actually a figure that's 20 years old. So it is outdated, and a lot of the nomenclature is outdated. But what I think it shows is how when I go in to see a new patient with a diagnosis of epilepsy, how I'm thinking. Is this an epilepsy type that we don't know the cause? So those that are above the horizontal line, are these epilepsies where we do know the cause and they're sort of below the line? Are they focal epilepsies? So most of the seizures that are focal in nature are to the left, those that are generalized to the right. And then what age do the kids present, sort of in these concentric circles going out? And so as we sort of talk to families, gather information on the history, fine tune that with maybe EEG, MRI things, we'd like to try and put someone into as specific of a diagnosis as possible. I will often say to my trainees, like, the term seizure disorder, which I know we use a lot, it sends kind of shivers down my spine because it tells us nothing, right? Seizure disorder can mean so many things. When a patient with diabetes, we don't say that they have a glucose disorder. We don't say someone who has a heart condition has a heart rhythm disorder, right? We try to be as specific as possible. And I think that this really helps in terms of how I approach patients. Certainly, I think it helps from the caregiver and the parent side because they can then identify with some other groups that are more similar to their children. And then more recently, it really has set the stage for studies of novel medications to see if they actually have a syndrome-specific indication. And I kind of mentioned that, have we gone too far? So now are we being too much of splitters as opposed to lumpers? Because now, as we build more data and evidence that these new medications work in various syndromes, the question then becomes, well, at what point could it have a role in any epilepsy type, sort of these sort of off-label use, which I'll touch on towards the end. So a couple of the syndromes that I'm just going to focus on here because it does set the stage for the trials are Dravet syndrome and Lennox-Gastaut syndrome, because again, the newer medications have really been studied in these patient populations and have actually received FDA approval for those specific indications. So just one slide on what Dravet syndrome is. So this is a clinical diagnosis. These are young children with no history of epilepsy, no epilepsy risk factors. They come in usually in that first year of life with a convulsive seizure. So usually a generalized tonic-clonic seizure, very often in the setting of fever. It can be prolonged upwards of 20 minutes. And then, often these children are given a diagnosis of febrile seizures and say, go on your way. And then in the months that follow, other seizure types occur both with and without fever. And this is really where some red flags should be going off in terms of the treating clinicians to say, could this actually be the initial presentation of Dravet syndrome? In 2020, we're in a much different era than we were just 5 years ago when genetic testing was not readily available. Now, it thankfully is readily available, and I think we are getting better at suspecting these early onset genetic epilepsies, not only just Dravet syndrome, but others. And then it is allowing us to approach them in a more specific way as opposed to just throwing broad treatment regimens in front of them. So why Dravet syndrome? So I can tell you that when I was in training, and it wasn't that so long ago, 15 years ago, Dravet syndrome was just something that it would be a sort of grand rounds if we actually had one, like so rare and so interesting. And really, I think it is a credit to patients and families who have come together. And this, is a slide from a screenshot from the CNN website back in 2013 when they put together the story on Charlotte Figge, who unfortunately passed away this year, about their use of medical marijuana as a treatment of her seizures. And I remember back this time being in California, and in California, medical marijuana was already able to be legal for medical purposes. There was this sort of onslaught of requests because people were tired of the old sort of conventional medications and were really looking for something that was a bit outside of the box that could potentially help their children. But lo and behold, the cannabidiol, so CBD, one of the many active drugs in the marijuana plant, has a long history. There are references in the Bible going back to 1800 BC of marijuana being used for the treatment of epilepsy. But then it was like 200 or some odd years that had to pass before the scientific community started to look more into whether or not these compounds could have anticonvulsant effects. And I think it's safe to say now that not only in the clinical trials that I'm going to go over with you, that there is escalating scientific evidence that support the beneficial therapeutic effects of the cannabinoids, but not only with regard to seizures and epilepsy, but also in the whole area of what we call neuroprotection. And so jumping ahead now, getting into the data that led to these these trials. And again, the reason why I want to present this core data is because we all want what's best for our patients. You all want best for your children or your loved one. And so we have to have expectations, right? And I think those expectations can be both informed by what has been described, and then we can also hope that we or our patients are outliers, right? We always want to hope for even better than what has actually been described. But I think at least if we go into it understanding where we're starting from, that really is helpful. So that there's 5 trials with publicly released data. There's still some ongoing trials that are all what are called randomized double-blind placebo-controlled trials, right? So if any of you have participated in a clinical trial, you know that this is stressful, but it's so important. To jump ahead in terms of the end, I want to thank you all for if you've entrusted the medical community with your loved one to be enrolled in one of these trials. It really is how we're moving this field forward. So there are these 5 trials. 2 have been studied in the syndrome of Dravet, 2 in Lennox-Gastaut, and 1 in tuberous sclerosis complex. And just to cut to the chase, overall, and this is all with Epidiolex. For the rest of this talk, I'll be referring to CBD as the sort of FDA-approved Epidiolex. Overall, this is a well-tolerated medication with the most common side effects being sleepiness, decreased appetite, diarrhea, and weight loss. And here is the 2 studies that actually, the data from the 2 pivotal studies in Dravet syndrome. On the left here was the first study that basically looked at placebo versus 1 dose of cannabidiol at 20 milligrams per kilogram. And you can see in the placebo group, there was a 13% reduction in seizures, and in the treatment group, there was a 39% reduction in seizures. And then there was a second study that also included a lower dose arm or group. So they had a placebo, 10, and 20. And what you can see here is, again, the treatment groups did better than those with placebo. And these are all statistically significant compared to placebo. And that while the higher dose was a little bit better, it wasn't substantially better. And there really, if you compare the 10 versus 20, there really is no difference there. But again, so this is the group, right? There's a lot of individuals in each of these groups, right? So there are going to be some patients that do worse than this, but some patients that do better than this. But as I pitch it to you all in terms of like, okay, I'd like to try cannabidiol next. Here's what we can expect. This is what you would hear from me if you were one of my patients sitting in the room with me. And I would say that exact same thing. Not everyone's going to achieve this. Some may do a little better. Some may not do as well. And then we get this initial improvement in the majority of patients. And then everyone wants to know, okay, been here, done that. We've had a drug before and it seemed like it was working for Johnny. And then afterwards, it just stopped working. So the honeymoon effect. And I think this leaves just a bad taste in all of our mouths, right? Because it almost is like, oh, I'm going to get this sort of false sense of, oh, we finally found something, only for the rug to be pulled out from underneath us. And I will say that is unfortunately still true with many of the new drugs. But I think thankfully, there are an overwhelming majority of patients who are tried on these drugs do actually have a longer lasting response. And so this is basically a figure showing that over time in sort of 12-week, sort of 3-month bins, 3 months, 6 months out to a year, how many people stay in the trial and how many people actually have reduction in seizures. And so you can see at the bottom, the WD is withdrawals. So there's always going to be some withdrawals. And whether those withdrawals are because the drug loses its efficacy, maybe there's some side effects that emerge, maybe there's just no reason. Maybe someone just says, I want off. All of those are being included here. But you can see the majority of patients over time do have this sort of what was seen in the initial placebo-controlled trials, right? Sort of this high 30, low 40% reduction in seizures. And then furthermore, if we look in, remember I said that that's the group, this 40% reduction in seizures. Some are going to do a little better, some are going to maybe not do as well. If we look at the so-called responder rates, right? And so we bin these all into 25% reduction, 50 greater than 75, and then 100% is seizure free, we can see that there's a consistent group of patients who over the year-long period have meaningful benefit, right? So it's not like you're just hanging in the trial and it's all sort of focusing on this one group, but those that actually have this even better response clearly continue to have that response over time. So that's actually, I think, an easier sell for me as a physician who's talking about these new medications as being a next step, to say that, again, this isn't a guarantee for everyone, but we at least have good data to support the initial efficacy that seems to be longstanding. So then moving into a different syndrome, Lennox-Gastaut syndrome. So very different syndrome. And again, when I give this talk to other neurologists, child neurologists, epilepsy providers, we all know that these two syndromes are so very different, Dravet syndrome and Lennox-Gastaut syndrome. And maybe I won't go through all the details here, but they are just so different. But one thing that they have in common is that there's still a huge unmet need with medications that are effective and well tolerated. And so it made sense to try cannabidiol in this patient population as well. And so same format here, 2 of the pivotal trials that were done and led to the FDA approval. The one on the left shows again, the responder rate and those numbers of patients that had a 50% reduction in seizures. And you can see, again, that 10 milligram dose, 10 milligram per kilogram dose was superior to placebo in the gray with a 36% reduction in seizures. And the higher dose was a little bit better, but not significantly better than the 10 per kilo. And then furthermore, the 75% reduction, at least in this first trial, it didn't meet what we call statistical significance, right? But anyone that looks at these bars, you look at it and you say, but wait, the 11's higher than the 3 and the 25's higher than the 3. So do I really care as a parent or if it's statistically significant? If I fall into that bar, it's significant to me. And I agree with that. I think that we just need to present it in that way. And lo and behold, in the second study, that number of patients that actually reached the 75% reduction in seizures was actually statistically significant. So again, you can see some themes here, right? These high 30s, low 40 response rates were similar in these 2 trials of cannabidiol of 2 very different pediatric onset epilepsy syndromes. And again, to follow the same sort of format, I won't go through every single bar here, but the longer duration experience has also been very reassuring. Again, you can see some withdrawals there, which are going to be pretty common. In my experience, sort of real world, I think because this drug is well tolerated in the majority of patients, that you tend to have less overall withdrawals maybe than medications that came out that we've used 10 years ago. So I think it compares favorably in that extent. And then again, the responder rates of those that are having 25% reduction, 50, 75, and 100. And keep in mind, these are diligent counting of seizures, which many of our families do. And I think it's up to every individual to decide, is 25% reduction in seizures worth it to you and to your loved one? Some may say, absolutely. Any reduction in seizures, as long as it's comes with tolerable side effects, is worth it. And that's why I do think that having these expectations and have it be supported by data is really informative. And then if we go back full circle to before all these phase 3 trials even started of cannabidiol, there was a program called the Expanded Access Program that enrolled many different types of seizures, Dravet syndrome, Lennox-Gastaut syndrome, but many other different epilepsy types. And this is the data that was just presented at the Child Neurology Society meeting last week to see how those patients are responding now over this 192 weeks, so almost 4 years. And again, there's a diminishing end there, right? You can see that the number is going down. That's partially because some patients may drop out. It's also partially because people entered into this trial at different times, right? So someone may have entered in midway through and are still on it, but they've only been exposed for 2 years. But I think this, very, very nicely shows that if you do respond, that the majority of those that respond continue to have some lasting response, and the majority stay on the medication. And for the interest of time, I won't go through that last one. Side effects. So it is not immune to side effects. We know that all drugs, right, regardless of whether they're natural or made in a lab, do have side effects. This is the list of side effects from that expanded access program, so over 800 patients. And I'll say that this is very consistent with what was seen in the randomized controlled placebo-controlled trials as well. So diarrhea, sleepiness, decreased appetite, upper respiratory infection. We don't necessarily know what to make of some of the fever and upper respiratory infection, right? We know that, and I apologize, as a pediatric epileptologist, I always say kids. I mean, and that's in the space I'm in. I'm not discounting if there are adults that are living with epilepsy that are on this presentation, or if a parent of an adult, and that's just what I'm used to, how I'm used to speaking. We know that our kids are in general more vulnerable to run-of-the-mill colds and maybe get some more fevers. And to the extent that this is something that's really due to the drug, I think is really unclear. So my real world information is okay, yeah, Dr. Sullivan, that's all great, but what are you really seeing now that we've had this drug available to us for a little over 2 years? So when you do see the improvement, you generally see it early, which is nice, right? You don't have to say, oh, let's start this drug and hang in there for 6 months and then maybe we'll see the effects. What I do is I do exactly what the label says. I start this 5 milligrams per kilogram and then increase, and then I kind of sit tight there and see how things are going. If we get a dramatic reduction in seizures, then maybe we don't go any further. If we get a reduction, but we're still unhappy with the reduction and want more, then we try to go up a little bit more. And then if we continue to see every little dose increase that I make, if we see dose-related improvement, then we continue to follow that trajectory. Sometimes, though, what happens is you go from 10 to 12 to 15, and you're just not, kind of like those bars that I showed you, right? You're just not seeing additional reduction in seizures. Then I just tend to back off and go to that sort of dose that we felt gave us that sort of that Goldilocks sort of most. There are some people who upfront say, oh, we need to reduce the on-fee. I personally don't do that because that interaction does not happen with everyone. And as long as we educate families that this is what to look out for, then if we see those types of side effects, then we can react accordingly. Decreased platelets is something that has just come up, again, hot off the press from a presentation at the Child Neurology Society meeting last week. So that's low platelets. Was seen in 11% of their new Epidiolex starts, and most commonly if that was added to a drug regimen that contained valproate, so contained Depakote. Again, small numbers, was not necessarily seen in larger scale clinical trials, but these trials, even though they may involve 1,000 patients, once a drug is approved in the real world, right, we get many thousands of patients exposed, and so I think it's important to sort of pay attention to these observations. But in the end, I think it is a broad spectrum medication. And again, I can say that because as a clinician, Dravet syndrome and Lennox-Gastaut syndrome are so different. And the fact that they had similar results in terms of reduction in seizures in those two very different syndromes makes me think that you could probably try this in almost any epilepsy type, and you could expect to see similar improvements. Now, I have to be careful when I say that because we know that FDA labeling and insurance approvals and things unfortunately dictate what we can prescribe and what we can't. But just if we're out there to say, well, the what if scenario, I think that what if scenario would favor using this medication and other indications. So I now want to talk a little bit about fenfluramine, probably the newest drug, and then the second one, last one I'm going to talk about is cenobamate. Those are the two that just recently were FDA approved within the last 3 to 4 months. So fenfluramine, for those of us that are similar to my age, I have vague recollections of fenfluramine when it was part of the fen-phen diet back in the late 80s and 90s. So why is this drug even being considered as an anti-epileptic drug? And I just think this is an interesting history because I think it parallels kind of the medical marijuana sort of observations that parents, that physicians are making in the clinic, and then they're like, is there a pattern here? And does this warrant further study? So back in 1984, Dr. Gusteau of Lennox and Gusteau fame used fenfluramine, which was known to be a serotonin drug, and so to help with treat behavior. And he had 3 children who had intellectual disability and these compulsive behaviors that they would self-induce fainting. And so he started fenfluramine in these 3 kids, and lo and behold, their behavior and their self-induction improved. So 3 patients. We're not even talking about epilepsy at this point in time. And then a year later, another kind of giant in the child neurology space, Jean Icardi in France, tried fenfluramine in 3 patients, this time with self-induced seizures. So there are some patients that can actually self-induce their seizures. And he was kind of thinking, oh, well, this self-induction for fainting. Turned out those fainting was probably also seizures. But the seizures resolved in all patients. But then it gets into chicken and egg, right? Was that the seizures improved because they stopped doing their self-induction. But when he did EEGs on them, the EEG abnormalities that happens when we flash the lights also improved. And that's where he just kind of said, I wonder if this could actually be an anti-epileptic drug above and beyond its impact that it has on this self-induction piece. And so then we fast forward about 20 years, and a small group of epileptologists in Belgium had treated a group of patients with Dravet syndrome with fenfluramine, sometimes upwards of 25 years. And they reported out on this that 7 out of the 11 patients were actually seizure-free. And again, I have about another 1-hour talk that has like 30 minutes of discussion in between that last slide and this slide. So, but for the purposes of time, and again, but it was these observations in terms of, I have these patients that are responding to fenfluramine going back, they have Dravet syndrome. Does this actually warrant further study in that specific condition? And that's what I'll show to you now. So these are the 2 studies of fenfluramine in Dravet syndrome. The outcome data here is presented a little bit differently. This is a survival, what's called a survival curve. And basically showing on the left, if you look at the red, those are the percentage of patients that actually had the different responses to reduction in seizures and placebo. The middle blue line is the low dose, and the higher light green line is the high dose. And so if you just look in the middle, the percent of patients that had a 50% reduction in seizures was 68% in the higher treatment group, 38% in the low dose group, and 12% in placebo. And then again, I'll call your attention to this 75% responder rate. So 50% of the patients in the higher dose group had a 75% reduction in seizures. And these are much like the Epidiolex cannabidiol trials. These are add-on therapies to standard medications in patients who have often been on many other failed medications in the past. And so this ability to now report out like a 75% reduction in half of patients is something that we're just not used to seeing in a refractory epilepsy population. And so was certainly, I think, I'm going on record in some of these talks that I give that we're, I think, setting a new bar of what can be achieved. Like 50% is great, absolutely, but we can do better. And I will put a calling out there to any of the other pharma folks that let's try to develop medications that can maybe give our patients a chance of achieving this bar. And then the second study here on the right, the main difference here, you'll notice there's only 2 lines. We did know that fenfluramine being sensitive to the dose and the exposure and the potential for any cardiovascular risk, which I'm going to get to in a second, that when added to a drug called stiripentol, which really is mainly used in patients with Dravet syndrome, that stiripentol has a lot of drug-drug interactions. And so if you introduce a dose that was too high and those patients were also on stiripentol, that could maybe expose them to too high of blood levels of fenfluramine. And maybe if there is a dose-related risk of valvular heart disease, maybe that would put those patients at risk. So there was a lot of work that went in to figure out what is the dose in the setting of stiripentol that would approximate the higher dose in the study that you see on your left. And so that's where that dose was used compared to placebo. And again, you can see a pretty broad separation from placebo, showing that it is in fact effective. And again, the 50% responder rate and 75% responder rates are shown there at 54% and 35% respectively. And then again, same format we see this great response in this short 12-week trial, but is it durable? And same sort of methodology issues. You have patients that are rolling into this open label extension trial at different points, right? So the number of patients that we have on this drug that have been out to 2 years is much smaller. But if you just look at the percent reduction in seizures, let's just go for the middle there, out 1 year, you can see that almost 121 of patients, that their average reduction in seizure frequency, or median reduction in seizure frequency, still approximates about 80%, which is pretty impressive. And then a different way of showing it here are the number of patients that have these different responder rates over time. Again, calling out that 75% responder rate of almost half of the patients, even in the longer term follow-up studies. So thankfully, all of the concerns about potential cardiac valve pathology or issues has been really addressed in the study. These patients were subjected to repeated echocardiograms every 6 to 12 weeks. And thankfully, we've still not seen any abnormal cardiac signals to suggest that there's a significant risk of cardiac valvulopathy. And the most common finding that we found was that the valve stayed completely normal. But we also found that when you had a valve that was normal when the patients enrolled in the trial, that some of them did go up to this finding called trace. So the tiny little, 1 drop of blood on the echo sort of leaks back into the chamber, and that's actually seen in normal healthy children. It's been well described. Upwards of 15% of normal healthy children walking around the street that get an echo done for other reasons will have this trace regurgitation. And so we actually think this is just background noise, right? We have things that fluctuate over time, and that's what this figure is showing, that with the green lines there, that if you started out with absent, you went up to trace, there were no changes made to any of the dosing here. It went back to normal, maybe went up to trace again, and you're just seeing this ebb and flow over time. And it was really those observations that dictated this risk mitigation or REMS program. So if anyone is being started on fenfluramine, they have to agree to get an echo done at baseline, and then have that followed every 6 months, just to make sure that we're being cautious and don't find any concerning findings. One slide here on Lennox-Gastaut. This is data that was just released earlier this year. It's not published yet, but same drug, same study design of a placebo, low dose and high dose. And we can see here that if you look again, statistical significance, the lower dose did not meet statistical significance when compared to the placebo. But the higher dose of the 0.7 milligrams per kilogram per day did achieve statistical significance. And then again, getting back to that 50% responder rate. So what percentage of patients had a 50% reduction in their seizures? So 25% of those that were assigned to the high dose compared to only 10% in the placebo had this 50% responder rate, and that p-value there, tells us again for the statisticians and the regulatory folks that that was in fact not due to chance and was statistically significant. And then this last syndrome, hopefully you're not getting all syndrome fatigue here, but just showing how we in pediatric epilepsy think about patients. There's this other syndrome called sunflower syndrome, which again, making the link back to these observations that were first made in the clinic, these patients that have photosensitivity or self-induction. And so one of my colleagues, Elizabeth Teal at the Mass General, did an investigator-initiated study of just starting fenfluramine in these patients. And we can see here that the seizure reduction was 84% in this population. So this is kind of what makes my day-to-day job very interesting, that we can sort of pick up on these sort of patterns of response, and I think families do the same thing, right? It's like been one of the advantages or disadvantages, depending on if your glass is half empty or half full, of social media and being able to identify with like-minded, or not like-minded, but similar patients, to say, oh, well, I have this other friend on Facebook whose son has the same syndrome as my son, and their doctor tried this. What do you think about that? And again, I don't like to practice what we call N of one medicine, because we know that it's much more complex on that. But I do think that the observations that are being made now, if we have the ability to talk about them, it can lead to some better treatment paradigms that ultimately will help our patients. So there was a lot of focus, obviously, on the cardiovascular risk for fenfluramine, which I think is, again, been very well characterized. It does have other side effects, right? It was part of a weight loss drug together with another drug, phentyramine, which the current prescription fenfluramine is pure fenfluramine and fenfluramine only. It did have a decrease in appetite. There was diarrhea. You can see some similarities here, right? The nasopharyngitis or URI, fever, and the weight decrease. So you'll see here that decreased appetite does happen. It's variable, doesn't happen in everyone. Even if it does happen, it doesn't always translate into clinically significant weight loss. And when it does happen, and when it does result in weight loss, in my experience, it's been very manageable. You supplement some of the kids with some higher calorie foods, and often the decreased appetite either resolves completely or gets to about 90% of where the kids were before starting. And therefore, that's why their weight continues and they continue to grow along their expected percentile in their growth curve. So again, to bring it all home in terms of real world observations, I'll skip over this dosing clarification because I don't think this is more for physicians, where they may read the primary literature and not know it's in the package insert. But again, the benefits that we see, it's really early. You see, we're starting these medications in patients who are having at least seizures on a monthly basis. And so we tend to see improvements in that first few weeks to a month. That when you do see that appetite suppression, as I mentioned, it's also seen early but resolves over time. There are limited drug-drug interactions that we're aware of, at least with the commonly used anti-seizure medications. So far, there's been no concerning signals for valvular heart disease. And again, the same theme that I mentioned with Epidiolex, you're showing improvements in seizure and frequency in Dravet syndrome, Lennox-Gastaut syndrome, and sunflower syndrome. Those are all, while they share maybe some of at least with the sunflower with some of the self-induction, they're all very, very different syndromes. And so in my opinion, it's very likely this is a broad spectrum medication. And I basically just said all that, got ahead of myself. So you're all saying, but I don't have one of these syndromes, or my kid doesn't have one of these syndromes. And, I just, what do I do? This is all great for those families and I'm happy for them. But is there anything else that has come out? So cenobamate, the brand name is called XCOPRI. Don't ask me what committees get assembled to name these these drugs, but XCOPRI, XCOPRI. So this is getting back more to our prior sort of pattern where we had adult onset refractory focal seizures. So this was a study that was done in patients 18 and up, again with focal onset seizures. And this actually is the dose response. So on the y-axis here on the vertical, you can see this is the median change in seizures, and then on the x-axis are the different doses. So placebo on the left, and then the higher dose all the way to the right. And what you can see is that if you look at the middle dose there, the cenobamate 200 milligrams, we get a median change in seizure frequency of over 50%. Okay, so that's not the 50% responder rate, right? This is the number of the percent reduction in overall seizures in patients that were exposed to that dose. The responder rate here is, and this is something that we have, I mentioned before with fenfluramine, that we generally don't see 75% responder rate. Well, bite my tongue, because here we go. We have a very different patient population, again, adults with refractory focal onset seizures. And you can see the responder rates here of the 75% responder rate is between 25 and 50%. And then we have a 90% responder rate of 25%. And then of course, what we all want, right, is seizure freedom, right, which is the 100% responder rate. And if you look at the 200 milligram dose and the 400 milligram dose, and I should have made myself the reminder here to report out the exact numbers, but you can see it's somewhere in between the 10 and 20% of being seizure free. Now, this is in the 12-week, 14-week clinical trial, right? We don't have enough time and data yet to report out. I don't have the follow-up slide of the open label extension to show how durable that is. But this is something that I think bears paying attention to, because as a pediatric epileptologist, it remains to be seen how I'm going to be able to use this in maybe a 12 and up. I tend to be a little bit chicken when it comes to the new drugs that come out with only adult data, and I try it in the sort of 12 and up first before I start going down younger. But I think certainly in the epilepsy community, we're really excited to see if the results that we're seeing in this clinical trial pan out in the real world. So I've started a few patients on this in the past month. It does actually, there were some isolated cases of a severe sort of systemic reaction called DRESS syndrome, and that can cause some organ dysfunction, skin rash, and because of that, it has a very slow titration schedule, so much so that it's almost, for anyone who's familiar with lamotrigine, with Lamictal, because of the risk of Stevens-Johnson syndrome, there's a very slow titration schedule. So this does take about 3 months to get up to that middle of the road dose that seemed to be, again, a sweet spot. So again, I just started a few patients on this a few months ago, and they're literally just reaching this dose. So too soon for me to give you the sort of real world observations yet, but certainly more to come on the cenobamate front. So I think it's important to put this in here, because I think I certainly live this with my patients and their families, and sometimes I feel like just a broken record. Someone comes in and still having seizures, and what do I say? Well, let's try another medication. And it's not me, just liking to write prescriptions. It's just really the main tools, that we have, in addition to epilepsy surgery and the evolving world of devices and things, which are lectures all unto themselves. But I do think it is worth continuing to try, right? We know that seizure freedom is a very high bar, but we also know that seizure freedom is not the only clinically meaningful outcome. And I had mentioned sometimes a 25% reduction in seizures is clinically meaningful to certain patients and families. We do know that recruitment into these clinical trials is becoming more challenging. And what is that telling us? Maybe there aren't so many patients out there that are having the requisite number of seizures on a monthly basis that they need to have in order to get into these trials. And again, are we only looking at seizure freedom? What if you have a reduction in seizure frequency or longer seizure-free intervals, right? That's, I would think, is clinically meaningful. And when you do look at the new drugs that have been looked at over time, a little over 10% of patients who change their drug will experience a 6-month period of seizure freedom. So is that seizure freedom forever? No. But 6 months, if we could identify those 10% of patients and give it a try, and assuming the drug is well tolerated, I certainly think that it's worth trying. And then lastly, the dreaded outcome that we aren't very good about talking about, but are hopefully getting better, is the risk of sudden unexpected death in epilepsy patients. It's something that I think we all want to prevent. And there have been some studies that have looked at the decreased risk of SUDEP when trying some of these new anti-seizure meds. So I want to close here with the new nasal rescue medications. I'm not so old that I remember when Diastat actually came out, and it was such a great addition to our regimen to have a rescue medication. And this was back in 1998 when the first studies were done of Diastat. And then when I took my first faculty job, there was this nasal atomizers were kind of coming onto the scene. And this was about 2008. And it was very clear that if we could figure out a safe and reliable way to give medications nasally, that was going to have a lot of advantages, especially as our kids got older and went to school, and there were the social implications of the rectal route of administration. And it's been very well studied now that the nasal route of delivery is similar to IV. And the problem is that now pharmacies stock this. Is the IV form, right? It's cumbersome. Your child's having a seizure, like, oh, where's the vial? I need to draw it up. I need to screw the thing on, and it's like, how am I gonna do this? So thankfully, the industry listened, and there are 2 new nasal preparations that are available. The first one that I'll speak about here is called Nasolam. It comes in this single-use 5 milligram spray. It's FDA approved for children 12, or for patients 12 and older. And I'm not going to go into how necessarily have what it's approved for seizure clusters. But if it works for seizure clusters, we feel very strongly that it can work to help abort a single seizure. The majority of patients that were included in the trials that led to this approval did have focal seizures, or focal seizures that then secondarily generalized. And essentially what they did is every patient got a test dose to make sure they tolerated it. And then if they were at home and they had a seizure cluster, so repetitive seizures, they were either randomized to get the treatment dose or placebo, right? And you can say, well, how can that be ethical that they gave a placebo? Well, we didn't know if it worked, right? We didn't know if this actually, the midazolam actually worked. And then if they did not respond to the first dose, whether that be 5 milligrams of midazolam or placebo, everybody was then allowed to give what we call an open label dose of the medication. And basically what they defined as success was the seizure stopped in less than 10 minutes and they had no other recurrence in 6 hours. So that gets into the seizure cluster definition. And when you looked at the treatment group, so those that actually got the 5 milligrams of midazolam up front compared to those that got the placebo, 53 versus 34% response. And so that was enough that was statistically significant and was able to get FDA approval. For those of you whose providers have prescribed this, you're probably aware that there is now, unfortunately, a little nationwide shortage. They're working hard to try and get that back. And what we've been told is that things should hopefully become more readily available this month, now that we're into November. And here's just a figure showing how those separate out, with those that had the midazolam and the dark blue and the lighter blue, and those are the probability of seizure recurrence. You can see is of no seizures, sorry, the probability of no seizures is higher in the treatment group. And then if you look at Valtoco, so intranasal diazepam, so the same exact drug as used in rectal Diastat, okay? And that's important because they were able to get this drug approved based on showing that the levels of diazepam that were seen in the bloodstream were similar after an intranasal dose as what it was if given rectally. And then they did a follow-up study to show that there's actually no difference if you give it in the resting state or in a seizure state. And that's really what led to approval. So it's almost, we infer that it is going to have the same treatment response in terms of percentage of patients that are seizure-free, as was actually shown in that New England Journal article back in 1998. This has a few more dosing options that are very, very similar to the rectal diastat formulations. And this is actually approved down to age 6. So a little bit more options there for our younger patients. And you can see that the 5 and 10, and then when you actually prescribe the 15 and 20, you basically just get a 5 and a 10, or you get 2 10s. And that's how, or sorry, 2 of the 7.5s. Sorry, so you get 2 in order to do 1 in each nostril for the higher dose. And so if you just compare them, again, this is not a head-to-head trial. And so, the academic in me, this is not meant to show that one is better than the other, because these are different patient populations and different studies. But you can clearly see that the percentage of patients that are seizure-free is pretty similar between these two compounds, midazolam and diazepam, when given intranasally. And so my real world observations with these 2 drugs, unfortunately, still too early. Thankfully, I don't have a ton of patients that have tried these and are using it all the time, right? And that's a good thing. But overall, those that have used it, they really like the user friendliness of it, right? It's overall been, oh, that was so great. It was so much easier. And then there's just like the real world of a babysitter or school, right? There was always this anxiety of like, oh, how am I going to show the babysitter how to do the little nasal atomizer? And so I think this really is going to translate into some improvements in quality of life for our patients. Unfortunately, the 5 milligram is the lowest dose for intranasal midazolam. So in the smaller kids, you would have to feel comfortable using this off label. And I do, because we've basically, when we were using the little nasal atomizer, drawing it up, we were using half of the dose on a weight-based basis compared to what was shown in the study. There are more dosing options for the intranasal diazepam. And then this whole thing about seizure clusters, are they all the same? So this is my own little color on this. I certainly have some patient populations where we know that if they have 1 seizure, they will have 15 seizures, and that will happen over a 24 or 48-hour period. In those patient populations, I prefer the diazepam just because it's longer acting, and so the idea is it's just going to give more coverage, as opposed to if I'm just trying to shorten a seizure. One of the advantages of midazolam, right, is that it's in and it's out a little bit more quickly. And so if it's meant to just and I don't say just stop, because every seizure is difficult to witness. But if we're trying to stop a single seizure, then I tend to choose more of the intranasal midazolam. But again, I haven't had enough real world experience with either of these new formulations yet to know whether or not this approach is really warranted. So to end with hopefully some time for some questions, hopefully, I've shown you the new medications that are available with various, syndromes of pediatric onset, as well as this one adult. So it's still big, big bucket or big group of patients that don't fit in there. And I think it remains to be seen, how these could play a role in those other syndromes. And the newly formulated nasal rescues, I think, are a welcomed addition to our practice and are effective and easy to use. So thank you.
Thank you, Dr. Sullivan. It's 12:58, and the next session is supposed to start at 1. So I'm not sure.
I went too long. I'm sorry. It's too long-winded.
No, we started late, remember? So do you want me to go over the first question if the other people are not on yet?
Let me see. Yeah, I can. Yeah, go for it.
Okay. Oop. Sorry.
guys.
So Sky said new FDA drug alert regarding cardiac arrhythmia with respect to lamotrigine. And her question is, what's your take on it for when to wean, when or on if or when to wean meds? My son is 16, diagnosed ESES and partial complex seizures at 7, seizure free now for 9 years, started with 85% ESES with every yearly EEG. Percentage has decreased until 1.5 years ago, in which we got a clean EEG. Meds are Lamictal, Neurontin, amantadine. He has ASD with the Lamictal warning. I'm especially concerned. I'm not keen on weaning during puberty, but neurologists wildly differ on what path to take. So as a parent, it's scary and crazy making. What are your thoughts?
Well, this is a perfect example of how I learn from my patients, because I'll be completely vulnerable and transparent that I had not heard about this FDA drug alert about cardiac arrhythmia. You know, I mean, with respect to the FDA, I mean, they're doing their job, right? I think what they see this a signal that it's their duty to report it to us. And we have had lamotrigine available now for 25 years, and there's been tens of thousands of prescriptions written. And I would have to say that well, until I read the data, I would assume that if this was something that was a major concern, I would have heard about it before now. But I would say that all these medications we know have very rare side effects, and that if you feel that this combination is working well for your child, that I personally wouldn't feel that you need to be overly concerned and rock the boat. Certainly there may be the role to get an EKG or screen for something like that. But I apologize, I don't know the specifics behind the arrhythmia warning. But you know, you'd be scared. I shouldn't. Well, I will say this, but if you read the package insert of many of these drugs, it scares the life out of all of us, right? Because there are these very rare side effects that can come up. But I think in a setting here where it sounds like this ESES was something that was very difficult to treat, you know, the risk benefit there may strongly weigh in favor of continuing as is.
So we have a question from Brandy.
Sorry to interrupt. We're gonna have to start our next session.
Okay.
Sorry.
You can email me if you have other questions. I'd be happy to try to weigh in. So my apologies for going a little late.
No worries. Thank you so much for your talk. Thank you, Doctor.
All right. Goodbye, everyone. Enjoy the rest of the conference.
Thank you.
Stay